Hi, everybody. My name is Alexandre Michi. I'm the chair of the Tele-Cardiology Working Group of the International Society for Telemedicine and eHealth. I have the pleasure to host today, along with Mirvat Alasnag, our webinar called Contemporary Practices in STEMI. First of all, I would just like to make a short introduction of our working group, and then I will leave my dear colleague Mirvat present the details of the webinar. I will just share my screen. The working group, Tele-Cardiology Working Group of
I think maybe we lost connection with Alexandro for a few minutes. I'm sure he'll jump right back in to introduce the International Society for Telemedicine and eHealth. But what I will do then in the time being is introduce the webinar tonight. As Alexandro mentioned, we're going to be discussing the contemporary practices for STEMI. The topics are ranging from complete revascularization, and we're going to focus on the latest trials, radial access for STEMI and the latest guidelines and what they say about using radial access. We're going to cover thrombectomy and the role of thrombectomy and the different roles of mechanical circulatory support during STEMI. And I'm going to briefly introduce our faculty tonight. We have Dr. Sunil Rao, who's a professor of medicine at Duke University, Durham VA Health System. He will be presenting the radial session. Dr. Khaled Al-Shaibi, he's the director of the Cardiac Center at King Fahd Armed Forces Hospital in Saudi Arabia, and he will cover thrombectomy. And Alex Truesdell, and he will cover the mechanical circulatory support in myocardial in STEMI, and he is from Virginia Heart, Inova Heart and Vascular Institute, Virginia, United States. So I'll hand over back to you, Alexandra. We had lost you a little bit, and I just went ahead and introduced the program tonight.
Thank you very much. So this is the first for me, the first time that the connections gets cut off. No problem. Thank you very much. So I have the extreme pleasure to introduce my dear colleague, Mirvat Alasnag, which is the director of Catheterization Laboratory of the King Fahd Armed Forces Hospital in Saudi Arabia. And Mirvat will present her presentation, Complete Revascularization. Thank you very much. First of all, I would like just to thank the effort that Mirvat put into this webinar. And I would like also to thank to all our 4 colleagues for participating. Thank you very much, Mirvat. So you have the word.
Thank you. So I'm going to quickly cover the complete revascularization in the setting of STEMIs. And I'm going to try to zip through this really quickly. Before I go into the data, I want to go over a few cases really quickly, and I need you to think about these cases as I move through my presentation. So this is an LAO caudal view of a female who presented with an inferior myocardial infarction. This is a 71-year-old female with baseline renal dysfunction. Her creatinine is around 180 micromoles per liter. The next case is also an elderly 75-year-old female who also came in with an inferior wall myocardial infarction. Her past history, she had a bypass graft in 2001. She's also a very poorly controlled diabetic with a hemoglobin A1C of 15. And finally, this is a 61-year-old gentleman who presented with an anterior ST elevation MI. His hemodynamics on arrival, his blood pressure was 80/55. Past history was relevant for having a bioabsorbable stent in the LAD in 2004, and that's when the scaffolds were very popular. 2 years subsequent to that, he suffered an anterior myocardial infarction in 2006 and underwent a bifurcation stenting of both the LAD and the diagonal branch with drug-eluting stents. In 2006, his ejection fraction was 30%. So bearing in mind these 3 very different patients, presenting to us. Let's go over the data, and then we'll revisit this one more time. So there is a wide range of studies that were published, starting from the PRAMI, CULPRIT, and finally the COMPLETE trial. The COMPLETE really had the largest number of candidates recruited, about 4,000 patients, and their mean age for all of them was about 60 plus. Again, the COMPLETE trial had the longest follow-up, about 36 months for all these patients. Some of them had FFR evaluation or physiologic evaluation of the non-culprit lesions, and some did not. If we look at the COMPLETE trial, less than 1% of those enrolled actually underwent FFR. Now, all trials actually ended up looking at composite of death, all-cause death, cardiovascular death, myocardial infarctions, and revascularizations. But if we focus on the COMPLETE trial, because as I said, it was really the largest and it was the most recently published randomized trial, there were several exclusion criteria. So any patient who presented with an ST elevation MI and had multi-vessel coronary disease and successful PCI of the culprit were actually enrolled in the trial. Exclusion criteria was anyone who already had planned revascularization, albeit surgical, or anybody who's had prior coronary artery bypass grafting. And these patients were randomized to either complete revascularization or culprit-only revascularization. They were both arms were placed on guideline-directed medical therapy consisting of dual antiplatelets, statins, beta blockers, et cetera, and risk factor modification. And the follow-up was approximately 3 years. There was a co-primary outcome of a composite of cardiovascular death and new myocardial infarction, or cardiovascular death, new myocardial infarction, and ischemia-driven revascularization. Secondary endpoints also included unstable angina and class 4 heart failure. But let's just look at the kind of patients that were enrolled in this trial. So the average was about 61 to 62 years of age, predominantly males. Diabetics were only 19%. Very few, only 2% or so had chronic renal dysfunction. Again, a small proportion of these patients had prior percutaneous revascularization. And when you look at their hemoglobin A1C, these were very well optimized diabetic patients with a hemoglobin A1C averaging in the 6%. Again, looking at when these patients, their creatinine was fairly normal, and looking at when they presented, the majority, 70% almost, presented in less than 6 hours. And if we look at, again, comparing COMPLETE to the culprit only, the most important in this slide is actually to look at the syntax score. So the syntax score, average syntax score in both arms was approximately 16. So this was low syntax score population that was enrolled in the COMPLETE trial. Nevertheless, what were the results and the outcomes? The outcome was culprit only had a higher cumulative incidence of the first co-primary outcome of cardiovascular death and new myocardial infarction. The median follow-up was 3 years, and NNT was approximately 37. Same for the secondary primary outcome, which also included ischemia-driven revascularization. Once again, culprit only was higher, and the NNT was 13 here. When we look at the safety and other outcomes that were examined, when you look at contrast-associated kidney injury, it was trending. It was numerically higher in the complete revascularization. There were about 7 versus 0 patients with acute kidney injury. Nevertheless, it was not statistically significant. And when we look at the other endpoints, they were not statistically significant. But of course, all-cause death and new myocardial infarctions was a significantly higher in the culprit-only arm. So in conclusion, the complete revascularization had reduced cardiovascular death, new myocardial infarctions, and as well as the secondary co-endpoint of cardiovascular death, new MI, and ischemia-driven revascularization. So the benefit of complete revascularization was similar in those undergoing culprit PCI during the index hospitalization, and several weeks after, with approximately 3 weeks afterwards. There was no significant difference in any of the other safety endpoints that I mentioned, bleeding, stent thrombosis, etc. There was a sub-study, the complete OCT sub-study, which I didn't focus on, and I pointed out the FFR, but perhaps we need to be addressing imaging as well to help guide us. And when we look at the non-culprit, there are 2 definitions we need to be looking at. One is obstructive, and that is if the lesion angiographically was more than 70%, and vulnerable if the lesion met OCT criteria for a atheroma. And this is just a slide, but nevertheless, when we look at the whole background of this, or the premise of the OCT sub-study of the complete trial, was whether there was benefit from routine non-culprit lesion PCI, maybe associated with a vulnerable plaque. We actually don't know that, and maybe we should be examining it. And thin cap fibroatheroma is a well-recognized feature of a vulnerable plaque. Should we be searching for it? And OCT is high-definition intracoronary imaging modality that can perhaps predict and identify these plaques. So this is one of the patients that was enrolled in the sub-study, and this is a patient who I believe had an inferior myocardial infarction, and they examined all three vessels. The mean pullback was 2.8 in this trial, and this patient 152 millimeters of pullback. Okay, so effectively what they wanted to see is, was it obstructive? No, yes. And was there thin cap fibroatheroma? Yes and no, and looking at these. And eventually trying to predict. Obstructive lesions are, so obstructive non-culprit lesions are most likely to be vulnerable, and this is what they concluded when they evaluated these lesions, the non-culprit lesions by OCT. So half of the patients had a non-culprit lesion with vulnerable plaque by OCT. Obstructive lesions, that is those with a 70% or more visual stenosis, more commonly harbored vulnerable plaque than those that had non-obstructive lesions. And this suggests that perhaps there's a benefit of routine PCI of obstructive non-culprit lesions in patients with STEMI who end up undergoing OCT for better definition. So if I come back to this patient that I had showed you earlier that came with a STEMI in his LAD, where we ended up stenting his LAD in his diagonal and performing bifurcation stenting, he eventually did well. But it was a segue to the next part, which is, and I don't want to stop too long here because Dr. Truesdell is going to touch on it with the shock and mechanical circulatory support. But if a patient does present with shock, I don't believe we can apply the same trial, which is the complete trial. But here, the culprit shock trial, what they did is, again, it was a randomized trial. They enrolled approximately 700 patients into both arms, where they underwent either culprit lesion only or randomized to immediate multi-vessel PCI. They followed up these patients 30 days and then 12 months and looked at all-cause mortality. So this is the landmark analysis. If we look at the first 30 days, clearly there was some mortality was higher in the multi-vessel compared to the culprit vessel. That was attenuated later on when you take it out to 12 months. So in patients with an acute myocardial infarction and cardiogenic shock, culprit lesion only PCI with possible staged revascularization compared to immediate multi-vessel PCI was associated with a reduction in all-cause death or renal replacement therapy at 30 days. The effect in the composite endpoint is persistently observed at 12 months, as I said. And at 30 days, the difference in all-cause mortality is attenuated over time. However, there is no increase in mortality after 30 days until 1 year. And in terms of the culprit lesion only, it's possibly associated with a higher incidence of heart failure hospitalizations and perhaps more frequent repeat revascularizations at 1 year. But overall, the results of this study support the guidelines that have been changed, the European guidelines at least that have been changed. And I'm going to try to stick with my time here, and I'll stop sharing my screen and turn it back to the moderator, Dr. Alexandra.
Thank you very much, Mirvat. So I will just ask you one maybe quick question from the audience. So how do you select those assigned to complete revascularization in the same hospitalization and those deferred or staged?
So I think it's going to differ from center to center and perhaps from patient to patient as well. You know, if a patient is living nearby and it's feasible and easy for the patient to go home and come back, we can do that and reschedule the patient within 2 weeks, 3 weeks, etc. However, if they're coming from far away and we are a tertiary center, we factor that in, that these are patients that are coming from remote areas and it may be difficult transportation-wise. But we also look at the complexity of the lesion and the patient themselves. So if the patient has renal dysfunction, if the subsequent staged PCI or the non-culprit PCI is going to be elaborate, then perhaps it's not wise to do it in the same setting and give the patient some time to recover from the STEMI and so on before we bring them back and stage them.
Thank you very much. So, dear Mirvat, I will leave you to introduce our following speaker. Thank you very much for this excellent presentation, Mirvat.
So it gives me a lot of pleasure to present Dr. Sunil Rao. He is the editor of Circulation, and he is, of course, a renowned radial first operator and an interventional cardiologist. He is going to go over the data behind using radial access during STEMIs. Dr. Rao, I turn over to you.
So maybe just your microphone.
Yeah, can you see my slides now?
Yeah.
Okay, great. Well, thanks very much for the invitation to present with this very distinguished group. I'm sure many of the people that are in the audience that are watching this are already very accomplished radial operators, and we've lagged a little bit behind here in the United States. So I'll talk about the data behind transradial primary PCI. We have several large randomized trials now, as well as some techniques to try and facilitate the use of radial access for STEMI in the setting of the door to balloon time metric. I don't have any consulting relationships with industry since March 2018. My institution receives industry funding for research, and another disclosure is that I am a dedicated transradial operator. This is what I'm going to talk about over the next few minutes. Really, when I talk about radial approach to primary PCI for STEMI, I'm going to talk about the why, the when, and then the how. So why? You know, we have several large randomized trials now that have examined radial versus femoral access in patients with acute coronary syndromes. This is a pooling of 4 randomized trials that Giuseppe Ando and Davide Capodanno did and published in the Annals of Internal Medicine in 2015, looking at one of the endpoints, which is major bleeding, defined a little bit differently in the different trials. But you can see the pooled data show an over 40% reduction in major bleeding in patients undergoing radial approach for acute coronary syndrome related PCI versus femoral access. The other issues around access site, of course, and when we're talking about STEMI, what we're most interested in is whether the patient lives or dies. And in these trials, there was a significant benefit of radial access over femoral access with respect to all-cause mortality defined at different time points in some of these trials. But the effect size was quite robust with an over 30% relative risk reduction. The challenge, of course, is that not all patients are candidates for radial access, and we need to understand what the role of femoral access may be. And this is where the SAFARI trial comes in. This is a very ambitious trial done by Michel Lemay, done with really very little funding. So really kudos to the trial sites that participated. The planned sample size in this trial of STEMI patients randomized to radial versus femoral access was, in fact, 30-day mortality, which is, you know, it's an endpoint that we should see more often, but unfortunately we don't. It requires large sample sizes. But in this trial, because these patients were suffering from ST elevation MI, the planned sample size was reasonable, 4,000 patients. Unfortunately, the trial was stopped early with less than half of the patients being enrolled. But the results are quite interesting. You can see that on the left-hand panel that there was really no difference between radial and femoral access with respect to the cumulative incidence of all-cause mortality at 30 days. And on the right-hand panel, you can see that while there was a trend towards a reduction in bleeding complications, it did not meet statistical significance. This could be, of course, because the trial was underpowered for both of these endpoints, but it also begs the question about what is the role of femoral access when we have a huge benefit of radial access. And I'll talk a little bit about that when I talk about the approach that you should use when a patient presents with ST elevation MI and you are trying to make sure that you fall within that door to balloon time metric of 90 minutes. Now, to the SAFARI investigators' credit, they did include the SAFARI trial data in a more comprehensive meta-analysis that they presented at the ACC 2019 as part of their late breaker and included as well in their publication, showing that even if you include the SAFARI trial results, which again were a neutral set of results comparing the 2 access sites, the pooled effect size for all-cause mortality still favors radial approach when it can be done proficiently and within the appropriate confines of the door to balloon time metric. Some of these data have spurred the adoption of radial access in the United States. I mentioned early on that we've lagged behind most countries in adopting radial approach. The latest data suggests that the United States is now above 50%, which has been a dramatic increase since when we first looked at it. We first looked at this in 2008, and at that time, the US was only 1% radial. What I'm showing you here on this slide is a little bit outdated now. These are data that Dmitry Baklanov published looking through 2011, looking specifically at primary PCI for STEMI, which has lagged the overall adoption of radial access for non-STEMI populations, including elective PCI for stable angina. And you can see that, again, there is an increase, but it's only about 6% back in 2011. We actually don't know what it is right now in the United States because those data are no longer reported. My sense is that it probably has increased as we have more and more graduates coming out of training programs being very proficient with radial approach, and of course now this very robust evidence base supporting its use. In 2015, which is the last time we looked at it, was about 18% in the US. Okay, so when should you do this? And what I mean by this is, when is a center and an operator ready to use radial access for ST elevation MI? The use of radial access in ST elevation, there's an additional dimension of complexity because time is of the essence. You need to be able to do these procedures quickly because we know that there's a relationship between rapid reperfusion in the setting of ST elevation MI and a reduction in mortality. This is what I'm showing you here is with fibrinolysis, but the exact same metric has been shown with primary PCI as well. Now, this is a really, really interesting analysis done by Neil Wimmer and Bobby Ye. Using data from two randomized trials, they looked at rifle STACS as well as the STEMI subgroup from rival, asking the question, how much delay can you have in door to balloon time and still preserve the reported mortality benefit of radial access? The underlying assumption in this paper is that you believe the randomized data. If you don't believe the randomized data, you should stop listening for the next few slides. But if you believe the randomized data and you think that radial access in fact does reduce mortality, the question is, how much time can I spend using radial access to reperfuse a patient before I start losing that mortality benefit? So it's a very complicated and very elegant analysis using Markov modeling. And what they found was that if you assume on the x-axis here that there's a 50% reduction in mortality with radial approach, and you draw a vertical line up and over to the y-axis, that means that you can delay door to balloon time up to 85 minutes. That's 90 minutes plus 85 minutes before the mortality benefit of radial access goes away. Now, let's assume that you just do not believe that radial access reduces mortality by 50%, but you probably buy that it reduces mortality by 20%. Well, then you can come over to the 0.8 line on the x-axis, draw a line up to the diagonal line, and then over to the y-axis, and you can see that there's a 35-minute delay. So you can delay door to balloon time up to 125 minutes before you lose the mortality benefit of radial access. An interesting thought experiment that certainly none of us want to test in the real world, but it does suggest that the mortality benefit of radial access is quite robust. But there are issues that are unique to primary PCI, as I mentioned, specifically if you're going to implement radial access. The first and foremost is that the entire cath lab team should have experience with radial approach in elective interventional cases. The reason for that is that you want the team to be able to set up the radial case quickly. You want to make sure you have the correct equipment on the table, the right kind of sheath. And then, of course, you want the operator to be very experienced with complex PCI using radial access before they tackle ST elevation MI. Not that ST elevation MI cases are necessarily complicated, but again, the clock is ticking and you want to be able to work quickly. I postulate that the success of a transradial primary PCI program is not dependent on the operator because they've already committed to converting to radial access. It's really dependent on the cath lab staff because the setup is the rate limiting factor. Operators who are proficient with radial access and who are committed can get access very quickly. They can place the guide catheter very quickly. But if this patient setup is not appropriate or not ideal, it can make for a very frustrating experience. Now, we published a paper through the Society for Cardiovascular Angiography and Intervention in 2014, what we call Transradial Best Practices, that has recently been updated just within the past year. But in that prior document, when the adoption of radial access for ST elevation MI was lagging behind in the United States, We come up with these recommendations purely as expert consensus. And like with all things that are expert consensus, there will be people who agree with this and people who disagree with this. But what we came to was that in order for a hospital to start doing transradial primary PCI, they should have at least 1 year of experience with a radial first approach to elective cases, have done at least 100 elective cases via radial access, and have a femoral crossover rate less than 4%. And that number of 4% comes from the Rival trial. The highest volume radial sites in the Rival trial had a femoral crossover rate of less than 4%. And that's why we came up with that. You may or may not agree with this, but I think for many of the sites in the US that are just getting started doing transradial primary PCI, this may be a very reasonable starting point. So how? Well, I think this falls into several categories. What tools do you need? Well, I think you need to be proficient with radial access to begin with. Ultrasound can be very helpful, particularly in patients who are hypotensive or in the pre-shock state, to make sure that you can gain access in the radial artery very quickly. In fact, there is an association between radial access and improved survival in shock patients with STEMI. You need to have some tips and tricks up your sleeve, like balloon-assisted tracking or guide extensions, which many of us are very used to using. So one thing that I tell people who are getting started with using radial access is that we have data now on mechanisms of radial failure, and they fall into 3 big categories: failure of access, failure of seating the guide catheter, and then ultimately lack of guide catheter support. And we know that older patients and patients who are very short have a higher risk of transradial failure, largely because of subclavian tortuosity on the right side. This has also been borne out in other studies where shorter than 5'5" if you're in the United States, or 65 centimeters if you're in Europe, have a higher failure rate than taller patients. And again, it probably is because of that subclavian tortuosity. So what we recommended was that in patients who are over the age of 65 or 70, who are short, hopefully you will know what some of these dimensions are when the patient comes in with this ST elevation MI, we recommend a left radial approach because that may be faster. And as you all know, there is the randomized talent trial suggesting that you may be able to save some radiation as well because of faster procedures. Again, this is an algorithm that we recommended based purely on expert consensus, that there are some certain time benchmarks that you should keep in mind so that you're not struggling with radial access while the patient is continuing to have their infarction and have a certain threshold for bailing out to femoral approach. I'm going to skip this data on ultrasound. I think we're all familiar with ultrasound and how it facilitates vascular access. I'm sure the audience is familiar with balloon-assisted tracking. This is a strategy where you can facilitate catheter delivery by protruding an angioplasty balloon, usually a 2mm balloon for a 6 French guide, halfway out of the guide catheter and deploying it at 4 atmospheres to create this smooth transition between the guide catheter and the wire. What about guide catheter extensions? These can be extremely helpful. This is an ST elevation MI in a patient who had prior stents in a very heavily calcified right coronary artery, where we needed a guide catheter extension. You can see in the middle panel that we've anchored a balloon and are advancing this guide extension all the way down to the infarct lesion. And by advancing it over the balloon shaft, you can keep it centered within the artery to avoid any kind of dissection. And then you can see here's a 38mm stent being delivered very, very easily using a 6 French guide through a guide catheter extension. So become familiar with guide catheter extensions. They can certainly help you. So let me go back one. So in summary, I think that for operators who are not very proficient or are just starting with radial access, it's important to have experience with elective cases. It's a systems change. It's really dependent on the entire cath lab staff being on board with radial approach and knowing how to set the patient up. Consider left radial access for post-CABG, older patients and shorter patients. But at the end of the day, it's important that we use our clinical judgment. Don't struggle with radial access while your patient is continuing to infarct. If you're having issues, there's nothing wrong with bailing out to the femoral approach so that you can get a good outcome. Thank you very much.
Thank you, Dr. Rao. So I think we're keeping pace very well here, but I have a question for you from the audience, and it is, how do you account for the mortality benefit with radial access?
That is a very, very good question. It's a curious one. You know, we know that the most tangible benefit of radial approach is in a reduction in bleeding, and the effect sizes that have been seen in the randomized trials are quite large. and probably beyond what we would expect for simple reduction in bleeding complications. There's a very, very interesting and elegant analysis done by Marco Valgemigli's group, published in the European Heart Journal a few years ago, looking at attributable deaths in the MATRIX trial. And what they have suggested with their analysis is that the large proportion of the reduction in mortality seen in the STEMI population in MATRIX was actually due to a reduction in acute kidney injury, which is a very, really fascinating kind of mechanism to think about. In that trial, patients who were randomized to radial approach had a much lower incidence of post-procedure acute kidney injury than patients randomized to femoral approach. So I think there's a lot more we need to know. It may be the bleeding, it may be the AKI, it may be both.
Thank you very much, Sunil. It was a great presentation. So I have the honor to introduce to you the following speaker. Dr. Khaled Al-Shaibi is the Director of Cardiac Center at King Fahd Armed Forces Hospital in Jeddah, Saudi Arabia. Khaled is I'm very happy to have you here. And can you please share your presentation on thrombectomy? Thank you very much.
Thank you very much. Thank you for having me. Let me just see if I can share the screen. Okay. Thank you very much. Well, I've been asked to speak about thrombectomy and its role in primary PCI. A question that frequently comes up when you're doing a primary PCI is what to do with coronary thrombus. We know thrombus is present in STEMI, whether it's angiographically visible or not. We also know that the large thrombus burden is frequently associated with distal embolization, microvascular obstruction, no reflow phenomena resulting in a poor or unsatisfactory angiographic result. All these factors we also know in increase in infarct size and increased mortality. It would seem self-intuitive that by removing coronary thrombus, we might be able to reduce the likelihood of these adverse events from occurring, and hence potentially improve outcomes and limit infarct size. For these reasons, several small trials were conducted in the first half of the last decade, which randomized patients with STEMI to aspiration thrombectomy to no thrombectomy in the setting of primary PCI for STEMI. The largest of these was the TAPAS trial that was reported in 2008. The results seem to support the biologically plausible hypothesis that thrombus removal prior to PCI was beneficial. The TAPAS trial randomized just over 1,000 patients to either standard primary PCI or primary PCI preceded with routine manual thrombus aspiration. The primary endpoint of the study was all-cause mortality with secondary endpoints of cardiac death and reinfarction. When we look at the one-year results, we find a significant reduction in all-cause mortality, a reduction in cardiac mortality, and reinfarction in the group assigned to routine manual thrombus aspiration prior to primary PCI. In large part because of the TAPAS trial, along with other smaller studies of aspiration thrombectomy in primary PCI, the ESC guidelines in 2012 designated Class 2A level of evidence B to thrombus aspiration in STEMI, while the ACC AHA STEMI guidelines in 2013 also made the same recommendation for thrombus aspiration, Class 2A level of evidence B. Following these new STEMI guidelines on thrombectomy, two large randomized trials of routine thrombectomy prior to primary PCI versus primary PCI directly without thrombectomy were conducted to confirm earlier published data and potentially strengthen the guideline recommendations for thrombectomy. The TASTE trial, published in 2014 in the New England Journal of Medicine, and the TOTAL trial published its results in the same journal a year later. Let's look at the results of these two landmark studies. The TASTE trial randomized just over 7,200 patients to routine manual thrombectomy prior to primary PCI versus primary PCI directly without thrombectomy. The primary endpoint was all-cause mortality at both 30 days and 1 year. The finding at both 30 days and 12 months showed no difference for the primary endpoint with an absolute risk reduction of only 0.2 and 0.3% respectively at 30 days and 12 months. The total trial randomized just over 10,000 patients to routine manual thrombectomy prior to primary PCI versus primary PCI directly without thrombectomy. It included a primary efficacy endpoint that was a composite of cardiovascular death, recurrent MI, cardiogenic shock, or New York Heart Association heart failure class 4, in addition to a primary safety endpoint of stroke. The primary efficacy endpoint showed absolutely no difference between routine manual thrombectomy versus PCI alone. While if we look at the primary safety endpoint of stroke, there was a significant increased risk of stroke with a strategy of routine manual thrombectomy, an actual doubling of risk of stroke with this strategy. An individual patient-level meta-analysis published in Circulation in 2017 looked at the largest 3 trials of routine thrombectomy in STEMI, namely the TAPAS trial, the TASTE trial, and the TOTAL trial, which collectively randomized over 19,000 patients, which comprises actually 86% of all patients enrolled in randomized thrombus aspiration trials. The primary efficacy endpoint was cardiovascular mortality at 30 days and was not significant between the 2 strategies, with a p-value of 0.06. But there was a significant increase in the risk of stroke and TIA in the thrombectomy arm, with a p-value of 0.06 and a study level p-value interaction of 0.02, indicating a significant interaction with stroke TIA in the patients who underwent manual thrombus aspiration. They further went on to look at the level of thrombus burden. And when they looked at the primary efficacy endpoint as related to thrombus burden, there was clearly a trend to a possible benefit on cardiovascular mortality with thrombus aspiration in patients with a high thrombus burden, 2.5 versus 3.1% with a p-value of 0.03. But this did come at a significant increased risk of stroke, with a p-value of 0.009 and a significant p-value for interaction between the endpoint of stroke TIA and the performance of thrombectomy of 0.04. The conclusion of the authors was, as a routine strategy, thrombus aspiration did not reduce cardiovascular mortality for patients with ST segment elevation MI undergoing primary PCI. An exploratory analysis of patients with a high thrombus burden suggested that thrombus aspiration may improve mortality, but at the price of an increased risk of stroke or transient ischemic attacks. Based on these large randomized trials, the FSCAI STEMI guidelines were updated in 2015 to make routine manual thrombus aspiration in STEMI a class 3 level of indication level of evidence A. The ESC guidelines followed suit in 2017, also making routine manual thrombus aspiration STEMI a class 3 indication with a level of evidence A. A recent publication in JAMA Cardiology, which was published in 2019, one of the co-authors is sitting with us today, Dr. Sunil Rao, looked at the pattern of manual aspiration thrombectomy during primary PCI for STEMI in the NCDR Cath PCI registry over the past decade. Reassuringly, it shows that as a community of interventional cardiologists, we are quick to adopt and change our patterns of practice based on well-conducted randomized trials, as indicated by a fall in the use of thrombectomy following the large randomized trials of TASTE and TOTAL, even before societies incorporated the results of these trials into their guideline documents. The take-home message. Manual thrombus aspiration should not be used as a routine strategy in patients with ST segment elevation myocardial infarction. Selective bailout use of thrombus aspiration in cases of a large residual thrombus burden after opening the vessel with a guide wire balloon may be considered in the ACC-AHA-SCAI 2015 focused update. It's a class level 2B indication realizing that there is an increased risk of stroke with this strategy. Further, larger randomized trials will need to determine whether improved forms of thrombus aspiration, maybe mechanical thrombus aspiration, can reduce cardiovascular mortality and determine its safety with regards to stroke. Thank you.
Thank you very much, Khaled. This was a very interesting presentation. I would personally have a question for you. So is there any role for manual thrombectomy these days, or for that matter, any form of thrombus removal in STEMI patients?
Well, to answer that question, let's first make it clear. Thrombus is not good. We all know that. And a large thrombus burden does negatively affect the results of PCI. It's just that manual thrombus removal is inadequate in obtaining the results we want in removing sufficient amounts of thrombus, and does carry a risk, based on the evidence available, of causing strokes and TIA. Personally, I still use it occasionally when there is a very large thrombus burden, because it does improve my angiographic result. But I do pay meticulous attention to how I perform it, and I make absolutely sure that there is negative pressure and aspiration ongoing as I withdraw the aspiration catheter back into the guiding catheter. Certainly more robust mechanical thrombus removal systems may be more effective in reaching our desired goals, but we don't have adequate data from large randomized trials for mechanical thrombus aspiration, such as TASTE and TOTAL. I think TASTE and TOTAL were able to recruit as many patients as they did because the technology is cheap and was pretty much available in all labs. This may not be as reproducible with mechanical thrombectomy devices that carry a much higher upfront cost.
So we'll move on to our final speaker, Dr. Alex Truesdell. He's going to discuss the role of mechanical circulatory support in the setting of an ST elevation myocardial infarction. So Alex, I turn over to you.
Great, thank you very much, Mirvat. Let me switch over here. So thank you very much for having me. So I'm going to speak about contemporary use of mechanical circulatory support in ST elevation myocardial infarction, a very broad topic. So I'm going to try and cover a lot of broad elements, but do so quickly. Here are my disclosures. So first, I think there's a matter of an issue of definition. So, you know, a lot of times I hear people talking about mechanical circulatory support use in MI, and there's a difference between ST elevation MI versus cardiac arrest versus cardiogenic shock, just as there's a difference in the different devices. So go a little bit through a little bit about the different potential roles, and then where I think future directions will lie. So one thing I think everybody can agree upon at this point, that every minute of delay in primary PCI for ST elevation myocardial infarction affects mortality. And we have lots of accumulated evidence in this regard. And so there's a lot of attention paid towards rapid revascularization. Although you heard from Dr. Rao's talk that we can make some exceptions, that, you know, some of the benefits, for example, in using radial access versus femoral access, maybe some delays are appropriate. And I think that's important because there's some question about that in terms of circulatory support as well, which I'll cover. Again, what are the benefits of timely reperfusion in ST elevation myocardial infarction? Well, again, well-established evidence of a reduction in infarct size, minimize myocardial damage, preserving LV systolic function, so that we're not just focused on survival, but long-term heart failure, long-term functioning, and an overall decrease in both morbidity and the hard endpoint of mortality, and again, firmly established at this point. So the question is, shock different? This is the FIT STEMI trial, I think a really elegant analysis looking at the interaction of rapid revascularization in different settings. And you can see that the fact that the importance of rapid revascularization is not less in shock, it's more pronounced in shock. And yet, while we know that there's all these benefits to early revascularization, and I would say that that is necessary, it's perhaps not sufficient. So since the shock trial, looking at cardiogenic shock, there's been a persistently elevated mortality. And to many of us, that would suggest that although revascularization for the acute MI subset of cardiogenic shock is important, that may not be the whole story, and that there's a limit to what we can do both with revascularization and with vasopressor use. And I really love this graphic by Naveen Kapoor, which when I think about the objectives in acute myocardial infarction complicated by cardiogenic shock, it's not just about restoring coronary perfusion and perfusing the myocardium, but also thinking about circulatory support. So maintaining perfusion to all of the vital organs, not just the heart, providing ventricular support to reduce the myocardial oxygen demand and support the heart itself. And I think in the shock setting, hitting all of these objectives become much more pronounced. This also highlights the vital importance of right heart catheterization. I think we've seen a resurgence of attention on hemodynamics and the use of Swan-Ganz catheter, driven partly by the structural heart realm, but also this increased recognition in cardiogenic shock that it's very difficult to treat something if you can't diagnose or identify. And in shock, you know, if you're, particularly when you're thinking about devices, if you don't know if someone's an LV dominant, RV dominant, biventricular shock, it's hard to select a device. You can also be fooled by these people that are normotensive but hypoperfused. And of course, there's some variety in shock definitions in clinical trials. But you know, this is really a fundamental skill set, is employing the right heart catheterization and evaluating the hemodynamics to make decisions. So there, you know, we have sort of an abundance of riches of devices out there, although I would submit to you there's no perfect device. An ideal device would be, you know, one that is easy to implant and percutaneously, since you know, most of these are going in the cath lab for the interventional cardiologists among us, that provides both circulatory support and ventricular support, is easy to manage, low complication rate, and is simple to remove, you know, afterwards. And that can sort of play well with others, because sometimes we need a mix and match of therapies. I think all of these therapies have to be put together in as part of a pathway. And this pathway is fascinating. And I think, as you can see, pathways evolve. I try not anymore to focus on blankets and loose stools in my management of acute coronary syndrome. But even then, I think this shows that it's important to have a plan of attack and have some, you know, algorithms as you're managing therapy. So in my center, we put together a cardiogenic shock team a number of years ago. And one of the first things we did, in addition to compiling our team members, was also to develop an algorithm to basically try and standardize care across the population, focusing on multidisciplinary team-based care, rapid identification of the shock state, using hemodynamics via the Swan-Ganz catheter, and then making decisions about who may or may not need mechanical circulatory support. And in our case, trying to prioritize that over high dose vasopressors. And then we have a whole background next level of therapy for once the patients are in the cardiac intensive care unit, to determine who's getting better, who's getting worse, who may need escalation of therapy, either to circulatory support or to different levels of circulatory support, and then who can be stepped down. And really trying to focus on multidisciplinary reevaluation, hemodynamic phenotyping of different shock states, and evolving our care strategies as patient status evolves. And then we sort of, over a couple years, tried to expand this beyond our hub hospital out to our spoke hospitals, to really, at least in our local community, try and develop a, follow the trauma center paradigm of level 3, 2, and 1 centers, where, institutions can maximize the therapies they have available, but then make sure that patients get to the places that they need. And in that level 1 center, really try and serve as a center of excellence, although obviously there's some question about how best to define that. But where you have, full spectrum of advanced and integrated therapies, a common set of providers, some high volume, and a research network. So, one big question in cardiogenic shock, particularly in mechanical circulatory support, is where's the data? Part of the problem is that, this is a very complex and multifactorial clinical problem with a lot of pathways to death. And admittedly, there is limited data, and trials are difficult to construct When they are constructed, there's often low enrollment, and it's hard to compare between trials. And there's a lot of different endpoints. And certainly, I think we would all agree that randomized controlled data is necessary, but I think there is some value to registry data, and I'm glad that we're seeing both operate in parallel. And some of the question is what to do in the meantime. So I'm personally excited about some of the randomized controlled data from the Danger Shock, Reverse, ECMO CS, and there's actually a number of other trials currently ongoing. And to date, there have been generally low trial numbers, except for IABP Shock 2, and that have either showed no benefit to circulatory support or shown only hemodynamic differences, which did not translate to any difference in survival. Which then, influences the current guidelines, which have a 2A for a balloon pump in cardiogenic shock complicated by, or MI complicated by cardiogenic shock, or with mechanical complications, but a class 3 in routine use of STEMI. And then again, you can see the recommendations for some of the other circulatory support devices. Getting back to registry data, I think there's a number of centers and pathways around the world, and many people are familiar with the National Cardiogenic Shock Initiative, which had a very protocolized approach to cardiogenic shock, emphasizing immediate circulatory support actually prior to revascularization in those patients who are hemodynamically identified to have cardiogenic shock. Utah, again, in a registry format, took a standardized approach to cardiogenic shock via a multidisciplinary team focused on hemodynamic guidance and group decision-making regarding support, and demonstrated from their pre-team cohort a 48% survival to a 61% survival, again, in a refractory shock population. This publication was just came out of the University of Ottawa just a month or two ago, also put together a multidisciplinary team focused on a consensus plan of care with hemodynamic guidance and group decision-making regarding circulatory support following protocolized pathways, and also demonstrated a pre-team survival of 42% up to a post-team survival of 67%. Here are our results in the Inova Heart and Vascular Institute. This was our first 18-month results, and then in the right panel, that's our 3-year results, although now we have up to we have 575 patients, and we'll be publishing some data later this year, which actually shows that we have equivalent mortality for both spoke and hub, which I think is important because really we want to try and equalize outcomes regardless of what hospital you present to, which has really been one of the great success stories in ST elevation myocardial infarction therapy without shock. Some things we set up to improve our outcomes was establish automatic triggers. If someone's hypotensive, tachycardic, or on pressors, that's a hard stop where we would encourage and almost enforce right heart catheterization. Using that data, we would assess whether people have hemodynamic criteria that meet cardiogenic shock, and then we would at least have a discussion and consider the employment of circulatory support. And with best characterization of the phenotype of shock to help best decide which device we would want to use, also focus on vascular access and avoidance of vascular complications, and then recognizing that where a patient is in hour 1 may be different than hour 3 or 6, and we have to have constant reassessment and changing gears as we go through therapy. Briefly, there's a lot of discussion about shock, ST elevation MI without shock, and one of the hot topics is door to unload, and this is just to clarify, in a non-shock population, there was a pilot, which was only a safety feasibility trial that looked at employment of specific axial flow and loading with the Impella device in ST elevation MI without cardiogenic shock, with a goal of reducing infarct size. I think it's an interesting trial, and we'll have to see in the pivotal trial how this pans out. And this obviously has to be measured against the risks of circulatory support. And really the concept here is, rather than just focusing myocardial oxygen supply, but also using some effort to address myocardial oxygen demand. There's been a lot of data about unloading. Unfortunately, all of it has been in pigs, sheep, and dogs. And so it's hard to know, how to apply that to humans. And that's where I think this trial will be very important to see if we can reduce infarct size and not just focus on survival, but focus on what we know is that hopefully reducing the scourge of heart failure, that we don't, take someone and keep them alive, but then burden them with long-term heart failure. And obviously this has a pharmacologic solution, but it remains to be seen whether in addition to rapid reperfusion, there's also a circulatory support adjunct that will be beneficial in this realm as well. The big question is big sheaths, big bleeds. So one thing, we talked about ultrasound guidance, radial access, and, some of these time delays. So any potential benefit of circulatory support, whether in shock or not shock, also really has to be considered alongside the risks of vascular access complications and bleeding, which have multiple immediate and downstream effects. One slide, cardiac arrest. Again, just when we talk about apples, oranges, and bananas language, the idea of circulatory support for shock, for just STEMI, and cardiac arrest is different. And we're using in cardiac arrest, we're typically talking about ECLS or ECPR. And there's been a lot of interesting, primarily European, although some data out of Minnesota showing the virtues. So in conclusion, it's important, I think, language when we talk about circulatory support to acknowledge and recognize that ST elevation MI without shock is different than with shock, is different from cardiac arrest. I would submit to you that any decision regarding employment of mechanical circulatory support cannot and should not be made without a very detailed hemodynamic analysis to decide, is it potentially necessary and what type may be necessary. And that I'm really glad to see a lot of clinical trials, but I'm also glad to see registry data alongside, because using and testing a tool, I think, has to be done within the construct of a protocol and a system of care. And I think it'll be interesting to see if we can establish some benefits of left ventricular unloading and circulatory support, the way we've very firmly established the benefits of early revascularization in acute MI, cardiogenic, or acute MI with or without cardiogenic shock.
Thank you, Alex. I have a quick question for you, and it's from other parts of the world that don't have access to various mechanical circulatory support devices. How would you recommend they proceed with managing shock patients?
Yeah, great question. And this is also, the real practical reality that we also have, that we always have to contend with. So I think, you have to focus on what is evidence-based. So we know in ST elevation myocardial infarction, early immediate revascularization, focusing on, appropriate and rapid platelet inhibition, radial access. So those are landmark fundamentals. And then what is available next? I think, there's been a lot of negative press, so to speak, about the balloon pump. I think it has a place when used appropriately. Sometimes that may be a bridge to next things. And frankly, if that's the only thing you have available, then that may be fine. In a lot of centers, depending on where you are, there also may be a matter of triaging, whether you're a hub center to a spoke center, that even if you can't do everything in your area, whether there's an opportunity to transfer. Although, as we know, in many, many parts of the world, that's not a possibility whatsoever. And then again, we really focus on all the best practices, enumerated by all the speakers before me.
Thank you. So at this time, we're concluding the lecture part of the webinar, and we're going to open it to the panel discussion and the questions that have come in from the audience. So Alexandra, I'll turn it to you now.
Thank you very much, Mirvat. So I would have a question for the first speaker, so which is you. How did the COVID situation change the strategy regarding complete revascularization? This would be a first question, and maybe a second question for you and for the panelists. How about COVID and stent thrombosis? Is there an increase in stent thrombosis rates during these times of pandemic?
So with complete revascularization, I think when the pandemic first started, our primary concern was to empty beds and to turn over beds very quickly. And so my inclination initially was, stabilize the patient, do the culprit vessel, and then bring the patient back and fix what needs to be fixed. With time, we started to realize that this COVID-19 is not ending. We're going to live with it for a while. And so we're back to the standard practice, really. So if the patient is someone that we can safely finish and do during this admission, everything that we can, perhaps if it's just a straightforward inferior MI, even in the same setting, try to finish as many vessels as possible. We do that because we don't know how safe it is to bring the patient back later. And even during the reboot phase, we don't want to have a huge backlog of patients. So if it is safe to do it in the same admission, we do it. Otherwise, you know, we defer it to a later time. And again, to transition to the next question, I'll leave it to Dr. Shaibi to talk about thrombosis, but I think on the same token, perhaps after Dr. Shaibi, Dr. Rao, people were wondering if radial access is actually even a better approach during COVID, and why you would think so.
Yeah, thank you very much. Maybe just one more question open to all of you. In France, there was a consensus regarding the pressure in the cath lab. What about your experience? So maybe each one of you, should the cath lab have negative pressure or neutral pressure or positive pressure?
Yeah, we had those same discussions here. I think, you know, and there's a tremendous amount of variability in what the different infection control teams at different hospitals said. Our infection control team has told us that negative pressure is not needed. So that's the guidance that we're following. I think the one thing we can say is that there are rooms where you can do both. And it is a very, very bad idea to do both, because you run the risk of sucking all of the viral particles and then blowing them out afterwards. So the one thing I think we could say is that don't do both, but we have elected not to do negative pressure, and I'd be interested to see what other people have done.
Thank you very much. Thank you. So, Mirvat, yeah, maybe Dr. Al-Shaibi can answer also this question, and also the one regarding stent thrombosis. Thank you very much, Dr. Al-Shaibi.
Well, everybody was talking about negative pressure, but as a matter of reality, many cath labs can't convert as easily to a negative pressure. They have to deal with what they have. So we have been working with a positive pressure cath lab, and that's continued throughout the COVID crisis. It's just that we have streamlined our work and dedicated a cath lab that is going to be only COVID positive. So we minimize the equipment in there. We make sure only the COVID patients went there. We had a separate area for entry and exit for patients to that lab, for donning and doffing equipment. It was all, they were all positive pressure labs, but we just rearranged the lab in such a way so that we dedicated a single lab to accept COVID patients into.
What about Alex?
Yeah, so I think Sunil's point is interesting, because again, the same discussions. So actually, we've converted all of our intensive care, and I'm intensive care unit this week, into negative pressure, rooms. We have added filtration systems to all of them. We didn't really fully do that in the cath lab, and again, more for just structural reasons, and have just focused on the the individual and group PPE instead.
So perhaps we move on to the next question about radial access for COVID patients.
Yeah, I think I've heard people say both sides. One is that radial is preferred, and other people say, well, no, I like femoral because I stand further away. I'm not really sure you're standing that much further away. I mean, maybe it's a few inches. So I think the general principles still apply. I would say in a COVID patient, there's no such thing as an emergency in a patient who's COVID positive. It's really important to protect yourself and the staff. Make sure you're donning and doffing appropriately. Then when it comes to the procedure, do what you are good at doing. If you are proficient with radial access, do radial access. If you're not comfortable, do femoral access. Probably I would say that a COVID patient is not the patient to start your radial program on.
Thank you.
Thrombosis of the COVID, right? So Dr. Shaibi, with that one.
What's that? I didn't quite catch your question.
So Alexandra was asking about, are we seeing more, the COVID era, are we seeing more thrombosis in our patients that are coming in with ACS?
I I don't think we've seen more thrombosis. I mean, I've had one patient who had a thrombotic episode, but it was not really related, well, it was indirectly related to COVID because he ran out of his medications and couldn't get them. So it was sort of an indirect COVID effect, but it was due to deficiency of dual antiplatelet therapy.
It's an interesting question though, right? Because we know based on some recent publications that the virus directly infects the endothelium. And it will be interesting afterward to see if we are seeing an increase in stent thrombosis. People are obviously worried about venous thromboembolic events as well. It seems like this viral syndrome lasts much longer than just the hospitalization.
Yeah, that's a good point. I mean, what we've seen clinically, and actually we've had various heparization protocols. We have a very busy ECMO service here with, unfortunately, a lot of these people critically ill. And you know, if you asked what was our answer on week 1 versus week 2 versus week 3, but talk about, you know, pulmonary and how much is that different from ARDS 10 years ago, 20 years ago, I don't think we know, because these were discussions I had years ago too. Ironically, unfortunately, all of the discussions with stent thrombosis that we've seen, and we've had people jump on, hey, this is COVID, and it just translated to inadequate antiplatelet therapy, or inadequate use of intracoronary imaging in the setting of COVID. So I'm not, again, just anecdotally, I'm not sure we can clearly state that, at least in the few cases we've seen, that was the culprit, but so much remains to be figured out.
Thank you. So I might ask Alex a question about his presentation. One of the audience members asks if using these devices decreases mortality, and which device is better to be used. Can you just drop a few lines on this, Alex?
Sure. 2 short answers are: 1, I don't know, and we don't know. And so that sort of answers both. So, you know, which device and does it decrease mortality? So, you know, there's so much debate surrounding this because there's not a ton, as we all know, of randomized controlled trial data. All of the trials pretty uniformly show improvement in hemodynamics. And so one could say, well, that's better, but has it clearly translated to survival benefit in randomized trial? No, it has not. Does that perhaps give you more time to facilitate decision-making? I think so. Has that been demonstrated? You know, it's been very challenging to enroll in these trials. A lot of trials have been aborted. These critically ill patients have so many pathways to death. It's sometimes hard to tease out one or the other. Also, utilizing a device in the absence of really good knowledge of hemodynamics is difficult. So, you know, Dr. Bill O'Neill always tells about a case someone had right-sided, you know, an acute MI, RV infarct, and put in a left-sided device and basically hastened the person's death. Was that the device, or was that inadequate understanding of the hemodynamics and misapplication of device therapy? So many unknowns. I would say we would all benefit from, you know, increasing emphasis on hemodynamic assessment and learning and familiarity. And I'm really excited for a lot of these trials. I think danger shock in particular, there should be some interim and early analysis by the fall. I think other people on this call might know more than I. And it'll be interesting to see if there's a signal. A lot of people propose that we can't do these trials until you have a system of care. And people have suggested if you look at the early trials of thrombolytics versus percutaneous coronary intervention, that it wasn't a slam dunk until we had system of care in terms of routing people to hospitals, door-to-balloon metrics. So I think, you know, you really have to put that all in the construct, and I think we need to see randomized controlled trials. I applaud everybody involved in that, as well as registries, and hopefully those can collaborate together and we can move the field forward. And everybody has to be willing to put aside their prejudices and enroll if we're going to do that.
So another question came up sort of linked to shock and access, actually. So in a patient who does come with STEMI and shock, what is the preferred access? I presume, Dr. Rao, if you'd like to tackle that first.
Sure. Yeah. I mean, I think again, it goes back to what you're most comfortable with. We prefer radial access at our center. We're starting to get very proficient with ultrasound. So in a patient who's hypotensive, we often will get radial access using ultrasound. I think that if you have decided that the patient needs mechanical support early and your decision involves the use of the Impella, single access approach using an Impella is it's a very elegant technique. It's very simple. I actually think that, it saves the patient from having two different arterial sticks. So in that setting, I think going femoral with a single access technique is actually a really nice approach.
Thank you. So I would have a question for both Dr. Al-Shaibi and Mirvat. What do you think about this? Does it often occur to you to have a large thrombus burden? So you don't treat immediately this lesion by stent, you just do GP2B3A and check it 24 hours or 48 hours afterwards. And the second question for Mirvat, what would you suggest, intravenous or intracoronary GB2B3A? We can hear you, Khaled.
The guidelines would, for deferred stenting, he would also give it a class 3 level of evidence B indication, although again, there are exceptions. I mean, we all, I'm sure, can quote cases where you have this huge right coronary that just full of thrombus, and you establish TIMI-3 flow, you put the patient on a 2B3A inhibitor, heparin for a day, you bring them back, and 80–90% of that thrombus is gone, and you're able to do a very safe procedure. But I think those are the exceptions rather than the rules. So most of the time you try and do it at during the same setting, unless there's an exceptionally large volume of thrombus, then the patient has to leave the cath. If that's going to work, the patient has to leave the cath lab with TIMI-3 flow. Otherwise, no matter how much heparin or 2B3 inhibitors, if the vessel is closed, that's not going to work.
Thank you.
Yeah, so with regards to the 2B3A inhibitors, whether giving it intracoronary or intravenously, so the data really doesn't suggest that giving it intracoronary is any more beneficial. However, for practical purposes, particularly for STEMIs that we're just rushing from the emergency room to the cath lab and so on, I've just made it a habit that I give the drugs on table, simply just to avoid having the IV line tissued, or, during the transfer, or it was just a quick, they just, put it in and shifted the patient. And it's not just the 2B3As, any drug that I'm going to give, I tend to just give it on table with me. Heparin, if I'm going to, give extra heparin dose or what have you. That's really the only reason.
Yeah, thank you. I personally do the same thing. So we have to wrap up our session. I would like to thank all of the speakers and thank you for your time and your dedication. Thank you for the wonderful presentation we just witnessed. I would also like to thank especially Mirvat. Thank you once again, Mirvat, for this excellent webinar, because you did most of the background job. I would like also to thank all the participants, and we had around 800 subscriptions to the webinar. And I would like to remind you that this webinar will be available on the YouTube channel and has been broadcasted on the Facebook page of the working group. Thank you once again to all the participants and to all the panelists and the speakers, and I hope to see you soon. Thank you.
Thank you very much.
Thank you. I have to thank the speakers for peeling away time to do this with us. So really, thank you very much, everyone. And Alexandra, thank you for the invitation.
Thank you. Thank you very much.
Thank you.
Stay healthy, everyone.
Good night, everyone.
Take care.